Hi everyone, welcome back to Neurospicy Nursing. This lecture is going to be the complications of newborns. Don't forget that this lecture video is going to have a quiz associated with it. So, um, it should pop up. I don't know if it's popping up on the screen of the video. If not, it'll pop up near the description box when it's time for a quiz question. Okay, so just keep your eye out for that, and let's go ahead and get on into it. All right, so the first thing that we're going to be going over is maternal substance use. So, what does this mean? I know it is kind of a touchy subject, but it is exactly what it sounds like. Mom is using a substance while pregnant. And the other thing that comes with that is this is something that needs to be identified, hopefully very, very early on. And it's not something that we find out, kind of like at birth, right? If we can find out while they're still in utero, then that's best, but that may not always be the case. And then once we figure out what's going on, um, we will also know that the newborn's response is going to be dependent on what substance they were exposed to. Other things that are going to be affected is how long and when during the pregnancy the exposure happened, like the first, second, or third trimester. There's three major categories, which are fetal alcohol syndrome, tobacco use in pregnancy, and then there's the actual drug or alcohol withdrawal. All right, so these are those three um, kind of categories that I just told you guys about. Fetal alcohol syndrome is caused by an alcohol exposure in utero. It's going to depend, like the actual severity of it depends on the amount and the duration of the alcohol that's been used. But some things that we can end up seeing are growth restrictions, CNS alterations, and certain craniofacial features. And then there's going to be other systemic signs that we'll see as well. For tobacco use, usage of tobacco in utero is going to increase risk for prematurity, low birth weight, SIDS. SIDS is not a complication that I've put in this lecture, but you guys will get a full lecture about SIDS because that one is going to be very, very important kind of on its own, if that makes sense. We'll talk about it. Asthma is another risk factor, as well as developmental delays. These babies are going to need super close monitoring because of that nicotine causing vasoconstriction, which is going to also reduce oxygen delivery to them just in general. So, drug and alcohol withdrawal. So, again, it all depends on when the substance was introduced to the baby when in utero and for how long. We're going to assess the baby using something called a neonatal abstinence scoring syndrome. We're also going to run some drug screens. We're going to check their electrolytes. Sometimes they do a chest x-ray just to make sure that they're ruling out any congenital abnormalities. And then just to remind you guys that any intrauterine exposure is going to ultimately and unfortunately lead to neurobehavioral changes, developmental delays, or behavioral delays, as well as withdrawal symptoms. All right, so drug and alcohol withdrawal syndrome, kind of going into it way more deeply because this is a very intensive topic. So, there are going to be system changes, okay? The central nervous system is going to have changes like increased wakefulness, a high-pitched cry, irritability, tremors, hyperactive reflexes. They can even have seizures. And these babies are going to be super duper sensitive to stimulation. So we're going to try to reduce stimulation, but we're going to talk about all the interventions in a minute. So we can also see excoriations on the skin, especially on the face from constant face and knees from all the constant movement. They can also end up with cardiac issues like tetralogy of Fallot, ASD, VSD, and PDA. We're going to talk about all of the heart defects in pediatrics, but I just want you to know that these names, like just kind of see them and recognize them. You don't need to know exactly what they are yet in mother baby. Okay, any metabolic slash respiratory issues that you'll see would include like nasal flaring, excessive yawning, mottling of the skin. They may even have tachypnea, sweating, or a fever. And then GI, we're kind of looking at poor feeding, regurgitation. They may have projectile vomiting. They may have profuse diarrhea and excessive uncoordinated sucking. Okay, medications for alcohol or drug withdrawal. For withdrawal management in the neonates, we're going to use a medication called phenobarbital. It is an anticonvulsant, and that's to kind of decrease the irritability of the central nervous system and to prevent seizures. Okay, interventions for drug and alcohol withdrawal. So the nursing care is going to include all of your standard newborn interventions that we talked about in the last video, but we're going to also include specific withdrawal care. Also, that's going to obviously be dependent on what they're withdrawing from, but withdrawal care is going to be added on top of that regular newborn interventions. So we're still going to perform the abstinence scoring. We're going to assess their reflexes. We're going to monitor their fluid and electrolytes, monitor their skin turgor. I mean, it makes sense, right? For having that profuse diarrhea and vomiting, there's that chance for dehydration. Another great thing to look at is going to be their fontanelles. Depressed fontanelles are going to be indicative of dehydration for the most part. And then bulging, you'll think of like hydrocephalus, stuff like that. And then we're going to watch pretty closely to how well they're able to feed. We're going to make sure that we reduce stimulation, swaddle them, and then if they have cocaine withdrawal specifically cocaine withdrawal, write this down, star it, highlight it, do all the things. If it's cocaine withdrawal, we are going to avoid eye contact, and instead of rocking them side to side, we're going to rock them up and down. Also, we're going to encourage high calorie and frequent feeding. Okay, respiratory distress syndrome. So, what is RDS? RDS normally happens when the baby doesn't have something called surfactant. That's going to lead to poor gas exchange and ventilation failure. There's a lot of contributing factors to it, with some of them being preterm labor. If you guys remember when we talked about giving moms like dexamethasone or betamethasone for preterm labor, it's to help with that surfactant to kind of prevent this. So this is what when we see, hey, they maybe didn't get the treatment they needed, or it wasn't given in time, or in enough time for prior to when the baby was being born, that now we have respiratory distress syndrome. Obviously, that's not the only cause. Perinatal asphyxia is another cause, but just keep that in mind. That's why we give the betamethasone, dexamethasone. Okay, there's other manifestations like tachypnea, nasal flaring, and retractions and grunting that you can see as well. We're also going to check their ABGs. We're going to check cultures for CSF, blood, and urine. Make sure there's no like infection there, right? Because that respiratory distress could be like pneumonia or something like that. We're going to give them a lung surfactant called Bractant. I can never say Bractant. And that is for them to actually start creating their own surfactant. If they do have an ET tube, remember we can't suction anything out of it if they were administered that surfactant for at least 1 hour. Okay, hypoglycemia. So for our newborns, hypoglycemia is going to be a serum glucose of less than 60 milligrams per deciliter. There are lots of risk factors like maternal diabetes, if they're an SGA or LGA, if they've had any stress at birth, or if they were a preterm infant. Some signs are going to be poor feeding, jitteriness, diaphoresis, weak cry, or lethargy. We're going to confirm the hypoglycemia with 2 consecutive low blood glucose readings. And obviously, the intervention with that is a heel stick within 2 hours of birth, making sure that we're giving frequent feedings, and we're going to monitor their glucose per protocol. All right, preterm newborns. A preterm is born between 20 weeks and 36 weeks and 6 days. The risk factors are going to include maternal hypertension, multiple gestations, if they're an adolescent in pregnancy, if they have any substance use, any cervical abnormalities, or if they have a previous history of a preterm delivery. Manifestations could include apnea, an increase in respiratory effort, low birth weight. They can have poor second swallow. They may be extra wrinkly, not have enough hair, or can have a very, very large head, and then weak grasps as well. Interventions are going to include making sure that we do a rapid assessment, especially on their respiratory, make sure like, hey, mom got their betamethasone or their dexamethasone. How are they breathing? Are they going to need to go to the NICU? They're going to be smaller, so they're going to lose heat a lot faster, so we have to maintain thermoregulation. We're going to give them non-nutritive sucking, and we're going to minimize stimulation, as well as make sure that I already kind of touched on it, but make sure that we really, really monitor their respiratory effort and provide respiratory support if it's needed. Okay, so the post-term newborn, it's going to be after 42 weeks of gestation. They're going to have dry, cracked skin. They can have really, really long nails, lots of hair. They won't have vernix because they're kind of past that point. And they are also at risk for hypoglycemia. Make sure that you guys know that as well. Complications are going to include an aged placenta, difficult delivery. They're going to have a higher perinatal mortality rate, and they may also have jaundice, which we're going to go into hyperbilirubinemia in a minute. We're going to intervene early and make sure we're checking their blood glucose. We're going to initiate feedings early, and we're going to monitor for any birth injuries that they may have because, again, that really difficult birth, they can end up with hematomas on their heads, that sort of thing. All right, hyperbilirubinemia. This is going to be a few slides. Just at the beginning, I want you guys to remember that we create bilirubin in our body due to the breakdown of red blood cells. Okay, so make sure that you guys know that that is how bilirubin is created. So we see bilirubin often in babies, especially if it's a physiologic issue, because they are having a difficult time conjugating their bilirubin. The buildup of the unconjugated bilirubin is what causes that yellowing color. So by putting them under the phototherapy, they're able to then turn their bilirubin from unconjugated to conjugated. Okay, it's a lot of science going on, a lot of words, I know. But just remember that's kind of the baseline pathophys of it, okay? Physiologic is going to be benign, again, caused by the breakdown of fetal red blood cells, excessive bruising, and even because they have immature livers. And it's going to happen after they've been out of the womb for 24 hours. So after that 24-hour period, it's physiologic if it's after 24 hours. It's pathologic. It's because of an underlying disease. It's going to appear before 24 hours. So normally, if it's pathologic, it's from blood incompatibility, but it can also be caused by an infection. One thing I also want you guys to remember is Conerticus. Never say that. Sorry, guys. That is going to occur when bilirubin levels reach 25 milligrams per deciliter. But remember, that is detrimental to a baby. It can cause brain damage and cause anemia as well. All right. Hyperbilirubinemia, again, with the manifestations and diagnostics. We're going to assess for yellowing of the skin, the sclera, and the mucous membranes. We're going to note the time of onset to determine whether or not it's physiologic or pathologic. And some of the diagnostics are going to include bilirubin levels every 4 hours, blood type testing, hemoglobin and hematocrits, home testing, and electrolyte monitoring. The interventions are going to include phototherapy, monitoring the vital signs, protecting the eyes, keeping the newborn undressed, except for if they are male, we're going to cover just their genitalia. We're going to avoid lotions. We're going to reposition them every 2 hours. We're going to monitor their eyes and nose and their daily weights. We also want to make sure that we watch out for other side effects like rashes, bronze discoloration, dehydration, or temperature instabilities. Alrighty, that is all I have for you guys today. Make sure you guys take the quiz. I'm going to do a little coming soon, but a little bit more in depth about bilirubin, how that works, as well as we're going to go over SIDS in its completely like own PowerPoint. Yeah, that's all I have for you guys. Thank you so much and have a great day. Bye, guys.